Bismillahirrahmanirrahim. Today, just talk in other season of brain talk, and this time we are talking about the craniometric points of the skull and the cerebral cortical surface. So, it's difficult to identify anatomical structure inside the operation room sometimes. So, identification of sulci and gyri before and performing the craniotomy can help us to delimitate the intracranial lesion and preserve as much as possible of neurofunctional and eloquent areas. So, we have here the most important cranial landmarks, which lead us to the functional area and anatomical areas in the brain. So we're starting from frontal points in the frontal side. Firstly, we will talk about the pterion. Pterion is in a combination of 5 sutures come together to shape a typical H. We have here the coronal, sphenodofrontal, and squamous, and the sphenoparietal sutures, which they unit in together. And this terminal is situated to like 2.5 fingers breadth above the zygomatic arch and 1.5 fingers breadth behind the lateral orbital rim. In other way, we can find like 3.8 centimeter above the center of the zygomatic arch. So here is the terminal area, and we can see like H shape. We have here the coronal, we have here the sphenodofrontal suture, here is the squamous suture, and here is the sphenoparietal suture, and here is the squamous suture. Here some ways to determine where is the pterion. First, we can put like a 2 finger breadth over the zygomatic and 1 finger breadth behind the orbital lateral part of the orbital rim. So the area here is the terminal. Or we can draw a line from the center of the zygomatic arch, 3.8 centimeter or 4 centimeter. We can find the pterion. So we have here another landmarks. It's called the anterior sylvian point, ASP. What ASP? ASP is enlargement of the cisternal area below the triangularis. This is the most important area where the neurosurgeon started to dissect the sylvian fissure. So here another picture from Broughton book, and we can see here is the sylvian fissure, and here is the anterior ascending ramus of the fissure, and here also anterior horizontal ramus. Behind or between the anterior horizontal and ascending ramus, we have the pars triangularis. In front of the anterior horizontal ramus, we can find the pars orbitalis, and behind the anterior ascending ramus, we have the pars orbicularis. So as you see here, the star here is the triangularis, and beneath the pars triangularis, here the enlargement of the arcuate membrane here in this area. We're starting our dissection of the sylvian fissure from this side because it's very wide, and starting to the paracellular or cellular area with any pathological lesions. So the anterior sylvian point is a cisternal-like enlargement of the sylvian fissure under the pars triangularis. So how can we find the ASP or the anterior sylvian point? Is by finding on the skull what's called the anterior squamous point, another ASP also. So the anterior squamous point is you can find it by finding the meeting point between the squamous suture with the sphenoparietal suture. As you can see here, here's the pterion, here's the sphenoparietal suture, and here is the squamous suture. Meeting point is called anterior squamous point. So as we see here the anterior squamous point, and here is Asterion. Here is the superior squamous point. In this another, we'll talk about it later. Here on this specimen, we have the anterior sylvian point, and behind it's called the inferior rolandic point. It's got like a 2 to 3 centimeter from the anterior sylvian point. So, what's the importance of the anterior sylvian point is starting, fissure or sylvian fissure dissection. Also, in this area, there is a very important structures called frontal triangularis and obricularis, which is the composed of Broca area. So if we there is like a distance from the anterior sylvian point, actually posterior to it, maybe like 2.5, we'll find the what's called inferior rolandic point. As we see here in this picture, is the anterior sylvian point, and behind it 2.3 centimeter, we can find the inferior rolandic point of the central sulcus. Can you know what's the name of this structure? It's called subcentral gyrus. It's most found in 80% of the people, and 20% of the people we cannot find this gyrus here. We just only in these people we have like central sulcus, extends to the sylvian fissure. So another landmarks of the skull is called bregma. Bregma is the connection between the sagittal suture and the coronal suture. So in the how to find the bregma? Bregma you can find it by draw a line from the nasion 12 to 13 centimeter. We'll find the bregma. So if we go to 4 to 6 centimeter behind the bregma, we'll find the superior rolandic point, or the upper end of the central sulcus, and the precentral sulcus is located maybe like 3 to 3.5 centimeter behind the bregma. Here is the bregma, and here is the sagittal suture or sagittal sinus, and here is the meeting point. It's called bregma. So the inferior rolandic point. This point is actually 2.5 posterior to the anterior sylvian fissure. So it's corresponding, this point to the anterior limit of the transfer gyrus of Heschel. So the Heschel, this gyrus is a primary illusory area. So TGH, or the transfer gyrus of Heschel, always kissing the postcentral gyrus, and the postcentral gyrus is a primary sensory area. TGH on the surface of the superior temporal gyrus corresponding to the Wernicke area on the dominant hemisphere, which extends, posteriorly to the angular gyrus. Temporal lobotomy should be or should never surpass the inferior rolandic point IRP. So in order to preserve the Wernicke area. Here we see this is the anterior sylvian fissure, and here is behind it 2.5. We will find the inferior rolandic point. The inferior rolandic point is the anterior limit of the transverse gyrus of Heschel, which actually the anterior limit of Wernicke area. Extending our lobotomy behind the IRP will make the Wernicke area injured. Here is how can you find the inferior rolandic point on the skull. So we draw a line from the tragus, or front of the tragus, 4 centimeter to the superior squamous point. The meeting point is actually called the IRP location, or the inferior rolandic point. Another location, here is called, or other landmark, it's called the inferior frontal sulcus and the precentral sulcus meeting point, IFS and PCS. So this is a practical neurosurgical key point that can help us to localize the precentral gyrus because it's just only posterior and over the precentral gyrus of this point. So it's corresponding, specifically to the face motor activation area. Here is the inferior frontal gyrus, here is the precentral gyrus, and this here is the face, or the meeting point is here, and here is the face activation area, and here is the precentral gyrus. Another location is called the inferior frontal. Sorry, how to find this? The inferior frontal sulcus and the precentral sulcus relation to the skull. We will find firstly what's called Stephanion. Stephanion is a point of craniometric at the level of the intersection between the coronal suture and superior temporal line. So behind this Stephanion, 2 centimeter, we will find this meeting point of IFS and pre-CS. As we see here, this Stephanion is intersection or meeting point between the bregma, or of the coronal suture, and the superior temporal line. Behind it, 2.3 centimeter, will find the meeting point of IFS and precentral sulcus. How to localize the Broca area? The Broca area can be localized at 4 craniometrical points. Firstly, we have Stephanion, and behind it 2 centimeter is behind the Stephanion is another point, and the anterior sylvian point, and lastly the IRP. So here is the Stephanion, behind it another point, or the meeting point of IFS and precentral sulcus. Another point is called the anterior sylvian point, and also the IRP. So in this area is the location of the Broca. Another location or landmarks of the frontal side is called the superior frontal sulcus and the precentral sulcus meeting point. Here is the superior frontal sulcus meeting point with the precentral sulcus in this area. So it's very important for this point for is related to the superior surface of the thalamus and also the body of the lateral ventricle behind the foramen of Monro. As we see here, this is the superior frontal sulcus, and here is the precentral sulcus. So here is the area of the thalamus or superior side of the thalamus and the lateral ventricle behind the foramen of Monro. The posterior coronal point is another craniometrical point. Is located 3 centimeter lateral to sagittal suture and 1 centimeter posterior to the coronal suture. This point is the location of the hand motor cortex underneath the bone. As we see here, 3 centimeters from the sagittal suture and 1 centimeter is posterior to the coronal suture. The area is activation of the hand. As we see here in this picture, here is the posterior coronal point, which is related to the hand motor area. The superior rolandic point, as we say before, is 5 centimeter or 4 to 6 centimeter behind the bregma. Now we're coming to the parietal key points. So we have the intraparietal and post-central sulcus meeting point, IPS and PCS. The intraparietal sulcus is related anteriorly with the postcentral sulcus and posteriorly with the transfer occipital sulcus. So this is location or is very important point to find the post-central gyrus and can also be used for neurosurgical procedure as a safe starting point for transsulcal or transcortical opening, and this point also is related on its depth to the ventricular pterion. As we see here, is the pre or post-center sulcus. Here is the intraparietal sulcus. Here is the meeting point of this two sulcus meeting point. Here is the superior parietal lobule. Here is the inferior parietal lobule. Here is the transfer occipital sulcus. How to find the intraparietal point is actually we will find firstly the lambdoid. How to find the lambdoid is 7 centimeter over the anion or 12 to 13 centimeter behind the bregma. So if you find the lambdoid over the lambdoid 6 centimeter above and lateral 5 centimeter, we'll find this what's called intraparietal point. So we come into the what's called the Asterion. The Asterion is or maximal raise point of the parietal tuberosity is located in junction of the superior temporal line with and the vertical line draw over the most posterior part of the mastoid and through the posterior limit of the squamous suture. As we see here, this is the mastoid. Here is the superior temporal line. Here is the squamous suture. If we draw a line from the posterior part of the mastoid and coming to is passing by the posterior part of the squamous and transected with the posterior part of the superior temporal line, we'll find the Asterion. The Asterion is over suspect of the supramarginalis gyrus. The supramarginal gyrus and angular gyrus, they belong to the inferior parietal lobule and separated from the superior parietal lobule by what's called interparietal sulcus. As we see here, he's on the specimen. We find this line here, drawing from the posterior part of the mastoid, coming to the Asterion, and the Asterion actually is the supramarginalis, and here angular gyrus. Here is intraparietal sulcus, and here is the post-central sulcus, and here is the superior parietal lobule, and this is the inferior parietal lobule, which composed of two structures. It's called supramarginalis and angular gyrus. So the sulcus, we have sulcus that separate, supramarginalis from the angular gyrus. It's called the intermediary sulcus of Jensen or Jensen sulcus. This sulcus is continuous with the intraparietal sulcus. The superior marginalis is found as the posterior part of the sylvian fissure, whereas the angular gyrus can be found at the most posterior part of the superior temporal sulcus. So regarding to the surgical complication of the parietal approach on the dominant hemisphere, injury to the SMG supramarginal gyrus or angular gyrus AG, that can lead to language impairment of Wernicke aphasia. As we see here, here's the sylvian fissure. The posterior part of the sylvian fissure is, is stopped at the supramarginalis gyrus, whereas the superior temporal sulcus is stopping at the angular gyrus. And here is the inferior parietal lobule, and here is the Jensen sulcus, and this whole area is called inferior Wernicke area. Posterior and the occipital points here will find what's called the occipitocranion, and this is the most prominent occipital cranial point on the occipital side. It's not the anion. You must differentiate between these two concepts, the anion and the occipitocranion. The occipitocranion is related to the superior aspect of the calcarean fissure and the base of the cuneus. Distance from the opposite cranion to anion, like 2 centimeter. this is the location of lingual gyrus, where is from the opus cranium 2 to 4 centimeter above, and actually it's related to the occipital cuneus area. Here is the cuneus, here is the lingual gyrus. So, in our approach to the occipital side or the occipital craniotomy, below the lambda, this is the very good, exposure or good approach, because there is no breathing vein in this area, and most of the patient of the approach, which make our approach or non-bleeding or non-invasive to the brain, than the parietal craniotomies. Lastly, the Asterion. Asterion is connection of the lambdoid, occipital mastoid, and parietal mastoid suture. It's important, to localize the transition from transfer to the sigmoid sinus. It's located, posterior to the external auditory meatus, 3.5 centimeter. As we see here is the Asterion, here is the lambda, here is the parietal mastoid suture, and here is the occipital mastoid suture. Meeting point is called Asterion. Below the Asterion is our cranectomy, which we do to the CB angle tumors. Lastly, Dr. Baz said, to perform, sophisticated cerebral microneurosurgical procedure, precise knowledge and proper identification of the brain sulci and gyri are, mandatory in addition to fine microneurosurgical technique, and obviously neurosurgeon cannot be rely only on technological tools. Thank you so much.